is William Batranzi, and I am a nursing student at the University of Jamestown. For this presentation, I will be viewing the National Patient Safety Goal focus on improving the safety of using medications using my clinical experience and the medical surgical unit at the Sanford Healthcare Center and Hospital. The national safety goals exist because medication error remains one of the most common and the most preventable source of patient harm. Its purpose is to reduce the adverse drugs events, and it focuses on a few key components: proper labeling to prepare medication, extracts, safeguards for high-risk drugs like anticoagulant, and verification technologies such as the barcode scanning. I choose this goal because medication safety touches every patient I care for on my medical surgical unit every single shift. Now let's look. The first theme in the literature is barcode medication administration, or the BCMA. Joshua and colleague in 2021 found that pairing automated unit dose dispensing with barcoding scanning measurably reduces administration error across 6 hospitals. Tiagos and colleagues in 2025 study on the bend unit show the other side of the coin. When nurses do not consistently scan, the technology cannot do its job. So together, these studies tell us the tool works, but only when it is well applied or well used, and we can see the benefit of that. So the nurses have a key role to play when it concerns implementing a safe medication error using the barcode. So the second theme is the independent double checking for high alert medication. Malik Cameron and Jones in 2023 found that ICU nurses face daily barriers, staffing pressure, interruptions, unclear roles that pushes them towards a quick side-by-side glance rather than a true independence check. Kowinski and a colleague in a large 2024 study actually found no significant difference in error rates between double checking and single checking, which raises an important question. Is independent double checking helpful, or it is just not being done independently in the first place? That distinction is centered to my recommendation later in the presentation. At my clinic site, I was in Fargo. The policy governing medication administration layout clearly specifically safeguard. Every medication passes require 2 patient identifier and the safe rights. Barcoding, scanning, and smart pump libraries are required whenever available. High-risk medication require true independent double check, which trigger a hard stop in the electronic medical record. Heparin has its own extra verification step, and patients are monitored for 20 minutes after setting IV, IM, and subcutaneous drugs are given. Any error is reported immediately. This policy is comprehensive. The question is how consistently it's followed in day-to-day practice, which I will cover next. Comparing the policy to real practice, in my unit, the Sanford policy requires bar scanning whenever the technology is available. In practice, my unit does use scanning for most medication passes, but I've observed work around during high acuity period when nurses are stretched thin. That matches exactly what the literature shows. Scanning works, but compliance drops under pressure, which is concerning because those high acuity moments are exactly when patients are most vulnerable to errors. So the same pattern shows up with independent double checking. The policy is explicit. Two staff must independently verify high-risk medication, which with a hard stop in the EMR. On my unit, the double check does happen, but I have noticed it's sometimes done side by side. One nurse pulls up the chart and the other glances over rather than each nurse checking separately before comparing. Malik and colleague found this exact pattern in their 2023 study, trying it to staffing pressure and workflow interruptions. So the gap isn't whether double checking happens, it's whether they are truly independent. And also I would also add on to this by saying that double checking is done, but most of the times we would see that done I observed one done during blood infusion, and I could see a real true of a double checking where both nurses would actually read the medication, go through it, while the other is attentively listening to it. Then they would have reconfirmed what the other nurses just to make sure that they are all on the same page, because they're doing a blood infusion, which is a high-risk medication with the consequences being very fatal to the patient. So I experienced it's being done in the unit, and I could see both nurses conducting a thorough and accurate check in that light. So my first recommendation would be to strengthen barcode scanning compliance, especially during the high acuity period where I observe the most workarounds. 3 concrete steps: real-time compliance dashboards review at each safe hurdle, peer championed role model consistent scanning under pressure, and fixing the physical or technological friction, like scanning availability that pushes nurses towards keeping the step in the first place. This directly build on the Sanford policy existing requirement, and it is supported by Jesuran and colleague in 2021 study, and Tiega and colleague in 2025. So we are just recommending a more support to this program by just making sure that the nurses during that rush hour, what we say, they are able to have clear access, fixed access, and I would also say like like at this our medical center, we are using the one Epic and I've forgotten the software, like one something the Epic. So I could really see how nurses are using that in medication administration in various ways. It is vast, but I think that most of the nurses are not either they're not well educated on how to navigate through that really broad software to master how to navigate through to properly and safely give medication, especially timely ones. Because I just remember a nurse before we started the shift, she called me and said, "Hey, I will sit here and I will get all my medications done here. We'll just go pick it up." I'm like, "Oh, how does that happen?" So she said, "You can do it on air where you connect this to connect somewhere." It was a bit different. Her method was so nice, and you could do it anywhere on phone. You could do it in there. She just had to link it to the internet and send it through the dispenser, and that was wonderful. But previously, I've seen nurses who just get the medication differently, or they mark them, and go. So there are so many ways in which you could use the software to your advantage and for the safety of the patient. That is something I think more education is needed in navigating through the software that is used in the hospital, just to make sure the patients are safe in terms of medication administration. So the next one would be my second recommendation targets the independent double check gap. First, a refresher on separate, then compare techniques so each nurse genuinely checks along before comparing notes. Second, a documentation prompt like the structure checklist or an initial sticker that makes the independent step visible instead of assumed. Third, and maybe the most important, raising the staffing. Raising the staffing and interruption barrier identified by Malik and colleague in 2023 because the nurse cannot perform a true independent check if they do not have the time or the quiet moment to do it. Komwisky and colleague in 2024 findings reinforce why this matter. If double checking isn't done correctly, we can't fairly evaluate whether it's working. So this is now to bring it together. Sanford medication administration policy readily reflects strong evidence-based safeguard, but the gap I identify is in the policy itself. It is consistent with execution under the real-time load work pressure, which the scholar literature confirm it's a common challenge, not something unique to many units. By reinforcing scan rate, compliance, and true independence in double check, and by learning on partnership with patient, families, and pharmacy, we can close that gap and keep the safety goal at the center of daily practice. Thank you. Here we have our references. And there we go. Thank you. Have a nice day.